So our next abstract is actually from our program in Austin, and it's going to be presented by Liz McCullum. Liz is not a physician. She's actually the head of our outcomes and research program, and she's going to be talking about longitudinal follow-up.
Good afternoon. On behalf of our team at Dell Medical School and Dell Children's Medical Center, I would like to thank the Congenital Heart Surgeon Society for the opportunity to share our experience. I am the program administrator of the Health Transformation Design Program, which is the outcomes and research arm of our Heart Center. Our group is fortunate to have specific and dedicated team members tasked with daily monitoring and registry reporting of clinical data for our medium-sized program. We were inspired to embark upon this project for the simple fact that patients with congenital heart disease are living longer than ever before. Therefore, tracking congenital heart disease outcomes is imperative. A high priority has been placed on tracking their long-term survival as a more meaningful outcomes measure. As a result, the Society of Thoracic Surgeons implemented a 1-year survival metric and has discussed implementation for 2- and 5-year survival follow-up in the coming months. Despite the introduction of this reporting field, a universal mechanism has yet to be identified for tracking long-term follow-up. At our center, all registry reporting is managed by a team of 6 dedicated outcomes specialists assigned to national pediatric and congenital heart registries. It is worth noting here that during the time of this study, follow-up for outcomes reporting was not part of the standard discharge teaching. Our goal was to figure out how arduous it would be to achieve complete 1-year follow-up after congenital heart surgery. Our program's infancy, size, and structure gave us a unique opportunity to provide some meaningful insight into this question. We hypothesized that attaining 100% long-term follow-up of congenital heart disease surgical patients after surgery will be very challenging for centers. We included patients from our center who underwent primary intervention between July 31st, 2018 and February 19th, 2019. International charity patients were excluded. Vital status was ascertained after full review of the inpatient and outpatient medical record. Patient demographics, survival, and dates of last clinical encounters were recorded. In addition to EMR review, patients and parents or caregivers were contacted via telephone in English or Spanish to assess a health status of alive, deceased, or unknown. Up to 2 phone call attempts were made. Descriptive, univariate, and multivariable logistic regression statistics were utilized. 104 patients were identified. Medical record review and phone calls determined 75% of these patients to be alive, 2% to be deceased, and 23% with an undetermined 1-year survival status. Of the 104 patients, the median age at time of surgery was approximately 6 years. 22% were non-white, 42% were enrolled in Medicaid, and 12% had been readmitted 30 days following their surgical discharge. EMR review yielded the status of 2 deceased patients. 1 patient was admitted during the time of the study. Therefore, 101 families were eligible to be contacted by phone, and 49% were actually able to be reached. Of those determined to be alive, 31 patient status was able to be determined by EMR review alone, 20 patients through phone call only, and 27 patients using both mechanisms. Adjusting for age at time of surgery, patients with an unknown mortality status were more likely to be white, not receive Medicaid, and more likely to have been readmitted within 30 days of their index operation. The total personnel effort required to achieve the 77% 1-year follow-up in this 104 patient cohort was 25 person hours, which amounted to approximately 14.4 minutes per patient. In conclusion, even in the context of a resource-replete, medium-volume program, 100% patient follow-up at 1 year post-index operation is challenging. Our evaluation with EMR and up to 2 phone calls allowed us to determine the 1-year vital status for 77% of our cohort. As a preliminary step towards improvement, our center has formally partnered with our cardiology colleagues to align outpatient follow-up with standard of care management. Additionally, follow-up for outcomes reporting is now part of our standard discharge teaching. We realize the well-controlled environment provided by the recent inception of our program. We believe families should be educated on the importance of ascertaining their child's health status on a long-term basis to facilitate being contacted in the future. Programs should be prepared to invest in sufficient personnel to conduct this continuous work around tracking rolling surgical interventions. Successful long-term follow-up with CHE patients will require a systematic and multidisciplinary approach that may include alternative methods to contact patients and families in the future. Additional tracking tools including patient identifiers would be ideal for optimized outcomes assessment. I'd like to give a special thank you to Dr. Charles Frazier and Dr. Carlos Mary for supporting this study, and to members of the research team, Kate Taylor and Michelle Mizrahi. Thank you for your attention, and I'm happy to answer any questions.
As people are getting to the microphone, I have one question first. This seems a very strong study, and the question is about expense. I mean, it looks like it's labor intensive as well as money will be needed. So do you have any understanding of how much this costs to do and to get this one-year follow-up?
Yeah, I would say that, as I mentioned, 6 outcome specialists, and so that would be like approximately a dedicated 1 FTE for each one of those. So I think it's regionally based on salaries, but probably anywhere from $60,000 to $80,000 per research, outcome specialist.
So I think, so the 6 outcome specialists our program has actually cover all the registries, so including STS, PC4, PAC3, CNOC, MPCQIC, et cetera, et cetera. That being said, I mean, you can see how it'll all depend on the number of patients that you have, obviously. So for 100 patients, even to just attain 77%, you're talking about 25 person hours already. So then as you start adding patients, and in order to try to get closer to the goal should be obviously closer to 100%, it is going to be a lot of money and a lot of resources. And that was part of the question that we were trying to figure out is exactly how much how much investment is this going to require.
Sure. Bill DeCampley from Orlando. Yeah, this was a very nice study. It's a small study, but it's novel. You know, we've not ever heard a study designed quite like this before. I think it's very useful for all the models that we're trying to develop for outcomes analysis in the future. In the data center, we try to follow about 6,500 patients with yearly follow-up. And I presented a slide earlier today where I showed the drop-off in our ability to follow up with number of years of follow-up. There's a curve that's disappointingly steadily downward, which basically predicts that we will ultimately completely fail in our underlying mission to follow patients for, quote, for a lifetime, unquote. It's not going to work. It's going to end at more like 25 years, maybe 30 years. So we need to do something different. So my question is, did you attempted follow-up through a couple of means. Well, one of them was just like phone calls. What have you thought about in regards to social media or web-based apps?
Yeah, that's an excellent question. Thank you, Dr. DeCampley. Social media is definitely one of the things that is a go-to. Since the study, we have actually started looking at the PRO module, which actually helps track some of the patient outcomes long-term, but limited by a quality of life assessment and only for indexed operations. And so social media is a great thing. Emailing, thinking about ways to actually automate communication with patients. But our program, because it's new and it's still fairly on the smaller side, just doing patient engagement on the outset when patients actually come into the clinic or come in for surgery consult, introducing them to a member of the team and getting as much information about them that will consistently stay the same throughout hopefully their child's life and then continue that transition into adulthood.
And I think, Bill, your point's actually very, very well taken. And I think we as a field have to start thinking a little bit differently on how do we achieve these long-term follow-ups. I mean, I think as Dr. Meyer was saying yesterday, we really want to follow these patients in the long term for their entire lifetime. But we also don't want to only follow survival, right? We want to see how they're really doing. So I think we need to start thinking about how do we develop an infrastructure to measure the things that actually matter to patients and families. So some of the research that we're doing is actually on what are even the measures that are most meaningful to them beyond survival. How do we then build an infrastructure based on social media, electronic engagement, and all these things to really get to a more meaningful follow-up. Now, one of the things that we found on this study was that a lot of the patients didn't meet the one-year follow-up based on EMR because they had been seen by their cardiologist at 10 months or 11 months post-operatively. So one of the things that we started doing is aligning those things. So now the cardiologist will say, okay, well, we'll see you, I mean, if instead of seeing you at 11 months, we're going to see you at 12 months, and that actually counts as the follow-up for 1 year post-op. So I think we just need to do a lot of the stuff, and some of the other things is the families won't answer the phone call sometimes. They think that the hospital is actually going to get billing and or whatever, you know. So actually educating them from the outset of we're going to be contacting you routinely to be able to get this follow-up will also be helpful.
Jim Kirkland from Birmingham. So congratulations on really an important study, because this should be the domain of the CHSS. I mean, the data center for years has emphasized the importance of really long-term follow-up, and I think this is all about expectations. And this needs to be the expectations of congenital heart programs. It's not about how much it costs. It's just like so many other things, when it's imposed upon you and leaders in the field begin to articulate the importance of getting this follow-up, then centers will get it. And this should be the domain of the CHSS to get this kind of information routinely on a large proportion of their patients. So thank you very much for emphasizing the importance of this to this society.
Thank you, Dr. Kirkland.